so great to have you today on my show. I really appreciate your time.
No, thank you very much for having me.
How are things in Sugarland right now?
Yeah. I'm used to Texas. I've been here for 10 years. Very nice.
Where are you from originally?
West is where I did all of my training, not just for med school, even nursing school and PA school. It was all the Midwest.
Gosh, you're a nurse, you're a physician's assistant, a physician. You've been a radiologist as well as a surgeon.
Interventional radiologist.
Interventional.
Yes.
Okay,
so I did the fellowship.
Okay,
I did all of it.
Okay,
yes,
got it. But that's still a lot of hats.
It is. I don't have any regrets about it at all.
Okay.
I needed to take baby steps. I'm first generation. My mom didn't even graduate from high school, paid my way through that's the story. And I did. And I'm super thankful for all those experiences.
Yeah,
really.
Of course, they shape you to who you become. So where is your family from originally? Mine came from India many years ago. And my parents landed in New York, and then we've been in this area since then. How about yours?
Both of my parents were actually born here.
Okay.
But the ethnic part is my mom is her Filipino Italian.
Okay. Yeah, you said first generation, so I wasn't sure. You meant first generation doctor or first generation?
All of it.
Okay.
Actually, it's the first generation to go to college.
Yes. Okay.
Yes,
got
ma'am.
it. Yeah.
Mm-hmm.
I guess it depends on who you speak with, because when people say first generation to me,
yes,
it's like a different connotation. So I didn't mean to offend you in any kind of way.
Oh, no. And I think that's a good point, actually. I don't want to misrepresent either. I just mean I'm the first generation of my people, whatever, to go to college. Like I said, my mom didn't graduate high school.
I'm sure she has many other skills and talents, though. I almost feel in certain ways I became stunted with medical school and residency. There were parts of me, I think, that stopped growing because of it. And it was almost like I had to catch up years later.
But specifically, if you are willing to share. In what way?
I think emotionally, right? You have to be able to compartmentalize. I think when you're doing such a rigorous training, medical school and training, and to put others first before your own life. And I think there's a price for that. And I'm hearing that it may be a little bit better when it comes to all that stuff, but I have a firm belief that people who are entering those kind of professions, not just medical school, nursing, what have you, that there should be some type of psychological care that comes with that, because you're taking on other people's issues before yourself, and that takes a toll on you emotionally. I don't care.
Yeah.
I do not care what anyone says to me. It does.
No, you can't separate that.
Yeah.
There's no way that you can separate it. So it has to affect you.
Yeah.
I agree.
And I think just paying attention to oneself when it comes to just making decisions, and it could be relationship decisions, all sorts of stuff. I just feel like there was just a delay when it comes to certain things. And then I think intrinsically, my intrinsic interests like music, arts, theater, writing, any type of creativity had to just be put on hold for many years.
Yes, I'm sure.
And
I don't know how kids do it these days. I see these kids in med school now, and they'll be talking about whatever. Maybe they're trying to be an influencer, or maybe they are, right? Or they're doing lots of activity. I did nothing in med school. Nothing.
Yeah.
I had 2 babies, and that's it. And I studied all the time.
You at least had 2 babies. You had that, right?
Yes.
That's a big feat.
It was huge.
So no, I didn't have kids at that time. So when I think about that's daunting as well. But
it was super stressful.
So for example, having this podcast and just doing things online and partnering with other people, those were things that would not have even come to mind at that time. And yes, the landscape looked different. There was no social media and all sorts of stuff. So yes, the landscape was different, but it could have been different. It could have been different. And I think it would have just fed a different part of myself. I'm not saying I would have had all this time to do it, but I think it would have been helpful to have those things as a human being.
I ask, so thank you for sharing.
Sure. You probably know, but I'm an internist by training. I see tons and tons of women, and I'm a women's health specialist, and I mostly focus on women in midlife. And there are a whole spectrum of things that happen: hormonal shifts, pregnancies, weight fluctuations, and a lot of women come in during a certain stage of life where they're like, oh gosh, Dr. Mandel, my legs, the veins, I'm having swelling, they feel heavy. What should women do during this stage?
So what I tell my patients midlife when they come in, the biggest thing that I focus on for all my patients, but I would say definitely these patients, is how much does it affect their quality of life? So I give my patients a quality of life survey to fill out before I speak to them, meaning that their intake paperwork. And I want to get a feel for how much do they feel like it's impinging on their quality of life. And then if they have other medical comorbidities that are also going on simultaneously, talking to them about prioritizing. So prioritizing a list. What bothers you the most? And it might not be their veins that bother them the most. Hypothetically, they have an issue, it's sciatica, it's really bothering them. They call it leg pain. I still educate them about vein disease, but I actually don't encourage them to get treated because really their chief complaint is sciatica. Yes, they might have vein disease. Let's educate them. But then I have them go to their primary care physician, talk to their PCP, and then once their real chief complaint has been addressed, hopefully they're getting relief, then they can come back to me if they feel like they still have issues with their legs. If the pain in their legs is taken care of, but they still have throbbing, aching, swelling, etc.
A lot of women also assume that having varicose veins, it's just a cosmetic issue. It's just a thing of beauty. But can you also talk about the medical impacts of having varicose veins, how it affects women, and what kind of treatments can be available for them?
If they're true varicose veins, big bulging veins that you can see on the outside of the legs, they're symptomatic, they're painful, they're tender, even patients like having a bleeding episode in the past. So if they're true varicose veins, they're absolutely not cosmetic. The thing that sort of separates those two is, do they have symptoms or they don't have symptoms?
Okay.
So symptoms like we've described, or is it purely, I just don't like the way these look? Sometimes we get patients that come in and they don't like the way they look, but I'm able to educate them. Actually, you might not think you have symptoms, but there is a little bit more of an underlying medical issue going on. Doesn't mean that they have to be treated medically. We'll address what their true concern is. But in terms of treatment options, certainly much different now than, say, 30 years ago when I was a nurse. So treatment options for these patients, we're going to get an ultrasound because we want to see what's going on a little bit deeper. I tell patients it's like a tree. If the trunk of your tree is big and stretched out and it's allowing blood to go backwards towards the feet instead of towards the heart, then you have a couple of options. You could do nothing and wait till your symptoms get bad enough that you feel like it's affecting your quality of life. You could do minimally invasive procedures, which is what I do. Okay. Those are called radiofrequency ablation. It's a big fancy term for heating and sealing veins with a catheter, ultrasound, and covered by insurance. And then if there's still big bulging varicose veins that are painful or have symptoms, then a phlebectomy, which is an in-office procedure, numbing medication, small little incision, and then I take out the big bulgy vein.
Okay. And can you walk through, a lot of patients have questions about not just insurance coverage, but when they do have certain types of procedures, how long those results would last for. Is it a permanent thing? Is it a 5-year thing or a 10-year thing?
That's a good question. And we addressed that in the very first initial evaluation with patients. these are treatments that I perform. They're not a cure. There is no cure for vein disease or venous insufficiency. And there's no way that I can predict how long a patient's going to be, we'll say, asymptomatic or decrease their symptoms after a procedure. What I can tell them definitively is it's a treatment. I hope to decrease your symptoms, and that might be for a period of 6 months, or it could be 6 years. And that's all dependent on somebody's, really their anatomy, and then maybe other factors. Do they hope to have more pregnancies? What's their occupation? Because all of those things exacerbate underlying vein disease. They don't cause it, but they exacerbate it.
What is the main cause of these things?
The number one risk factor is genetic.
Right.
So if one parent, it's in men and women, so I think that's important to discuss or just mention, because sometimes people think it's just female disease. It's not. It's men and women. If one of your parents has it, you have a 50% chance of having it. So it's the number one risk factor. Both, it goes up to 90% chance.
Okay.
So that's the number one risk factor.
I thought I survived my genetics. I'd gotten pregnancy and then a certain age hit. And it was a couple of summers ago. And one of my kids was like, "What's that?" And I was wearing shorts. It was very hot outside. And I just knew. And I looked down and I was like, how could I have missed that vein? It was right there. And I was like, okay.
Yeah.
It was one of my parents and it was 50-50.
Yes.
And I won the lotto.
You did.
The varicose vein lotto.
Yes. Yeah.
So these are some of the questions, and it's great to be talking with you about this because I have to go through this with patients. Your career started as a nurse, as a physician's assistant. You were in the ICU, and then you became an interventional radiologist. What led to your journey towards specializing in vein treatment? What inspired you to do this?
If I'm completely honest, it wasn't really inspiration, actually.
Okay.
It was more of I didn't want, when I finished fellowship, I actually returned back to the hospital where I worked as a neurosurgery PA. There had been a change in the Department of Interventional Radiology where the hospital fired the whole department and brought in a new person. So it wasn't really inspirational in that I was a brand new fellow starting out in interventional, which is a very broad subspecialty. And I just found that it wasn't really conducive to a new fellow learning, at least for me. So it didn't take too long. And I really started doing some soul searching and looking at my options. And I knew I wanted to be, instead of the jack of all trades, I felt like it would be better suited for me to be the master of one.
Okay.
And I had the catheter skills because I had trained in interventional. My residency was 5 years, and then I did a fellowship in interventional. And all those years, which was 6 years, I had used catheters. And so I felt like I could really, that would be a great fit for me. I did, like I said, I did my research. I looked what was out there, but I needed that to be fulfilled professionally. I needed to be an expert in something versus doing a lot of things. And I really didn't feel like I was doing all those things really well.
Okay.
So I wouldn't say stumbled upon it, and I'm extremely happy I did.
Yes.
I love what I do.
And then you founded the Reincke, am I pronouncing your last name correctly?
That is correct, yes.
Reincke Vein Center in Texas, in Sugar Land, about 4 years ago. Is that correct?
Yes. Yes, ma'am.
Yes. What inspired you to do that? And what has your experience been as an entrepreneur?
So it was a similar situation where at the time I was part of a small group. Okay. I was a partner. There were 3 physicians and there was just 3 of us, and I was outvoted, and they wanted to sell to a private equity firm. And we did. And it just conflicted with my professional goals, which I have a strong desire to provide one-on-one patient care in an environment where there's plenty of time and for patients to educate them, to discuss their concerns, and to answer questions. The model was changing. Once the private equity firm came in, it became more of a business model.
Yeah.
And that kind of conflicted with me professionally. I had already started thinking I need to open my own practice. And so I did. It was about a year later, I saved my money and I opened the doors in September 2021 for my own center. It's me. It's owned by me. All decisions are made by me.
Yeah. So you are the CEO, the medical director,
yes,
and everything.
Owner. Yes.
So the treatments that you provide, obviously, you do a lot of education for your patients, but you also have other ways of educating your patients in terms of not just the conditions, but the treatments that are available. Can you talk about that in terms of all the digital content that you offer for patient education?
Yes. That's actually been a level up, much more of an emphasis recently, just because I felt like there was a bit of a gap that I was missing and I could throw the net a little bit wider. So I started doing videos, short little videos where I address maybe common questions that my patients are asking me. And yeah, like short form content. And I've been putting it out wherever. Sometimes the ability for people just to have that at home, that's going to trigger something like, oh, I just didn't even realize that was an option. Or that was even, I thought that my legs were just swollen every day, that this was a normal thing. So it was very intentional that I started doing this. And we can already see that it's having an impact. We have patients that are calling in and coming in because they said, oh yeah, I saw Dr. Reincke, I saw this video. I feel good about that.
There are some pitfalls with social media, what have you, but I think this is one of its positive effects, that you can reach people that you otherwise wouldn't have been able to reach. And I think it's fascinating, honestly, in terms of patients that come to me and partnerships that I'm able to make with people who are interested in similar things that I like to talk about. I think it really levels the game in so many ways. But you do more than just that. You have partnered with community groups like Univision and LGBTQ groups, and you're also very active with health fairs. Why is that community outreach such a priority in your practice?
I think from a personal level, that's where I came from, meaning I came from very humble beginnings. I remember us having food stamps and having to fill those in order to get groceries and different items that we needed. And so I've never forgotten that. And I feel like it's a privilege to give back in that way. I specifically reach out to groups that I know are going to be servicing disadvantaged, undereducated, sometimes we're uneducated. So it's not just by chance that I'm going to those health fairs. It's really intentional efforts that I'm putting forth to go to. Baker Ripley had a big health fair downtown Houston that was all for Hispanic patients, and none of them had insurance. It's both personal and professional. And I do treat some pro bono patients. I don't like to say that too loudly because I don't want that to be the expectation. But to be honest with you, yes, I have all those patients that I went and saw at Baker Ripley. I offered to treat all of them for free because they didn't have insurance. And we had one lady that ended up, we were waiting for her to get back from Mexico, but ultimately she has very advanced disease. And I do hope that she will take us up on it.
I think there are times when, and I'm very exclusive about who I will treat pro bono and when I give my services away without expecting any kind of monetary benefit from that. That being said, when I'm questioned, when I do that, I always tell people that the universe has a way of paying you back for that.
It
may come years later, or it may come in other opportunities. But for those of us who come from humble backgrounds and beginnings, it is important to stay in touch with that side of ourselves, because I feel it actually makes us more attractive to other patients that are able to obviously to pay for their care. But that is obviously not the reason why either you and I do it.
Correct.
So for those women who, and this may fall even with women who are educated, many women don't necessarily know when they should be taking care of their vein health seriously. Like we touched up on that in the beginning of the podcast where we talked about certain symptoms and when should women say, okay, you know what, this is just a varicose veins. I'm not having anything else. Or when should women seek a vascular specialist or an interventional radiologist because they're having other issues?
I think any time that they have questions, come see somebody. For me, I give free consultations, like legitimately free, right?
Mm-hmm.
I want to give them education. So if it's something that they feel like they need more information about, go talk to somebody, talk to your primary care. You do not need a referral to see me. You shouldn't need a referral unless it's an insurance issue. But if somebody's offering a free consultation, you don't need a referral to go to them. That's the beauty of free consultations. A lot of people don't give them anymore. To answer your question, however, for me, I tell patients, if your symptoms are bothering you and they're progressively getting worse, you are potentially noticing more veins on your legs, or your swelling has increased, or it's now cramping. Now you have new symptoms on top of older symptoms. Go see somebody.
Yeah.
That's what I say. In a sense, it's not their job to figure out whether or not it should be something they need to address. If they have a concern, go talk to the specialist and let them educate you and work together collaboratively to decide, is this something that you need a little bit more, that you might need treatment for?
Yeah. I think it's really important for these types of patients to be established with a primary care physician because there are obviously different types of swellings that can happen in the leg. You want someone to be able to distinguish, is this coming from your heart or potentially any medications that you may be taking versus the veins that are not working properly. I, in my own practice, talk a lot about midlife changes and how that affects our bodies. When women have varicose veins and some of the symptoms that you were describing, the swelling, the heaviness, how does that affect other things like their exercise, their energy levels, their mobility? How can taking care of their veins support a more active lifestyle for them?
What I see is that if you're having symptoms that are affecting those things, if you have symptoms in your legs, such as swelling, night cramps, restless legs, and then those are preventing you from doing things like exercising, walking, just regular activities, daily living, cooking, cleaning, shopping, whatever that is, it's going to affect your mental health, your physical health, your confidence, etc. So it's not, again, going back to, it's not just going to affect one aspect of your health. It affects all of it. When they get treatments, we always tell them, we may be able to treat, if this is like a box of your symptoms, whatever part of the vein disease is contributing to, we hope to decrease those symptoms. But there might be other things. So we certainly set expectations, letting them know, hey, just because you get treated, it doesn't mean that all of your swelling or all of your leg cramps, restless legs, heaviness are going to go away. That's why it's important for us to work in conjunction with patients about, here's what I can do, but we need to work together. And your part in this is, after you're treated, I'd like to see you do some just walking. That's the best thing that I can recommend for my patient, on a treadmill, outside, whatever they can do. Or if say, for instance, they have really bad arthritis or some medical condition that precludes them from doing weight bearing or it's painful, I talk about swimming, or non-weight bearing exercises that they can do. So I try to work with them together, but certainly it can definitely impact their exercise, mental health, confidence, etc.
The other question and concern that women often have, and obviously this is not just excluded to women because men can have veins too, but I'm speaking as a women's health specialist. Often my patients are very busy, they're working mothers, and one of their concerns is the downtime required. What is the most effective treatment? And I understand that one treatment may not be the most effective for one other patient versus someone. So in terms of, let's say, sclerotherapy versus ablation versus phlebectomy where you remove the vein, what are the typical downtimes and recovery times with each procedure?
For me, each one of those procedures is an in-office procedure. All of those patients are back to their normal activities the same day. I would say the most uncomfortable of those procedures is probably the phlebectomy, where I'm taking out those big, bulging, painful varicose veins. And I usually just tell them, take it easy for today. You should be back to your normal exercise activities tomorrow. There's no like bed rest, downtime, etc. for those procedures, which is the beauty of the procedure, really. Because they used to do vein stripping procedures. Vascular surgery would go in, it was general anesthesia, surgery, and a 6-week recovery time. Things have dramatically changed. So these are minimally invasive. In terms of after the procedure, I think a realistic kind of expectation for a patient is you're going to have some bruising, some tenderness along the course of the vein that I treat, especially with radiofrequency ablation and phlebectomy. But that's well managed with ice, which will decrease inflammation and swelling, as well as just an over-the-counter non-steroidal anti-inflammatory, if they can take it, if there's no contraindication to that. I have never, in 10 years of practicing exclusively vein disease, I've never once written for pain medication or narcotic.
So what's next for Reincke Vein Center?
Right now, like I said, it's a little bit of a level up, but not crazy.
Yeah.
So my goal was just, I've been doing it for 10 years. I've established my reputation. I have a good patient base, et cetera. I just wanted that little extra piece where I was incorporating in the outreach with the education, but via social media, videos, teaching. I have added in allowing different types of either students or physicians to rotate. So I started out with family practice physicians. I've now included, I have high schoolers that are interested. This summer, they just started in medical specialties. So I've included that. I have ultrasound students who are rotating with us every month now as well. And then I think, honestly, I'm not ever going to be at the point where it's going to be like multiple centers with multiple physicians. That doesn't suit me. And it's not where I want to be. So I'm not looking to, the way that I practice here is not about numbers and goals related to numbers. And when I say that patients or procedures, we don't work like that. So I'm very happy with where I am. And I've learned a ton just recently, that educational videos and stuff. So I'm really pretty happy.
And if we wanted to look for these videos and find you via your website and social media, where would we go?
My website's Reincke Vein Center, Reincke Vein, VEIN Center.com. We have blogs, we have videos, short like TV spots that I've been on. Instagram is Reincke_Vein.Center. And then I do have TikTok. It's solely for education, and that's Dr. Tonie Reincke. I do have a YouTube as well. It's Dr. Tonie Reincke. Okay. So that's where all of my videos and education are.
Perfect. I'll make sure that we capture all of that for the show notes. But it's always good to obviously have people who are listening to it be able to immediately go and look you up.
Yes, thank you.
It's been very educational. I think this is informative for a lot of people.